At this time, I have the privilege of introducing the keynote presentation, which is going to be given by two internationally renowned speakers. Dr. Carolyn Clancy has served as Acting Deputy Director of Veterans Affairs since January 20th, 2021. Previously, she served as Assistant Undersecretary for Health for Discovery, Education, and Affiliate Networks. Dr. Clancy also served as the Veterans Health Administration Executive in Charge and has served as the Deputy Undersecretary for Health for Organizational Excellence, as well as serving 10 years as the Director of the Agency of Healthcare Research and Quality. The second presenter in this last presentation will be Dr. Beth Taylor. Dr. Taylor assumed the role of Assistant Undersecretary for Health for Patient Care Services and Chief Nursing Office in March of 2020 at the Veterans Health Administration. In this role, she serves as Principal Executive for Oversight of Nursing, Social Work, Caregiver Support, Connected Care, Pharmacy, Sterile Processing, Geriatrics, and Extended Care, along with Population Health, Patient-Centered Care, and Cultural Transformation, Physician Assistance, and Rehabilitation Prosthetics. So needless to say, she has a lot on her plate, and we are very privileged to have these two speakers. So at this time, I would like to turn the floor over to Dr. Clancy. Thank you.
Well, thank you so much, Kevin. I'm just beyond proud to tell you about how the Veterans Health Administration responded to the pandemic. So in this presentation, I am thinking of myself as sort of a warm-up act to Dr. Taylor, since nursing was just so utterly essential to our work. But part of my role is that our current acting undersecretary for health thought it was very important, and I was applauding this all the way, for us to review our experience as a very, very large enterprise. And so I served on the two-person steering committee for the external independent contractor that helped us with this work. So what we want to talk to you about today is how VHA leveraged our unique assets in responding to COVID-19. And then Dr. Taylor will talk about nurse education and training and why nursing is truly the first and last line of defense. So one thing you may not be aware of, and I think this is critically important because most people are not aware of it. We often say that VHA, the Veterans Health Administration, has three missions: research, education, and clinical care, which is absolutely correct. But we also have a fourth mission by law, which is that in the context of public health emergencies, we serve as something of a backup, if you will, or safety net for the rest of the healthcare system. So to make this extremely practical and understandable, you can see that we provided a huge amount of personal protective equipment, and this is as of about a month ago, to our partners and collaborators in the community, and about 438 non-veterans were literally admitted to our hospitals, which I think is quite astounding. Any of you who follow VA may remember that we had a real crisis with access in our system, particularly in Phoenix, Arizona. Well, Phoenix this year was the star of the show in Arizona, providing care to a lot of inpatients when the private sector was completely maxed out in terms of capacity. We also provided a great deal of support, and Beth will have more to say about that, to the state veterans homes, which are under the jurisdictions of states, but where many of the veterans we serve often end up. So we are the nation's largest integrated healthcare system, but if I were really honest with you, I would tell you that prior to the pandemic, the old adage that if you've seen one VA, you've seen one VA, was more often true. We could not possibly respond to the pandemic that way. And together, our colleagues at all facilities started to act like a real enterprise. We are also a very important source of, as I mentioned, healthcare education and training. So about 70% of the physicians in this country actually got some of their clinical training at a VA, and just under 60% of our docs on staff hold a faculty appointment at an academic affiliate. So very, very old research program that was unbelievably busy this year. So prior to being asked to serve as acting deputy secretary for the department, in my prior job, I led all of the work of our academic assets and also our work in healthcare innovations. And I was just awed by how rapidly our people stepped up to the charge of enrolling veterans in vaccine trials, in actually examining through health services research how we were doing. And what's very, very important is more than 60% of our researchers are also clinicians providing direct patient care. And another unique aspect of our system is that we have what is sometimes known as a patient-centered medical home. We refer to it as PACT teams or patient-aligned care teams. So we also have an electronic record. Now, some of you may have read that we're about to get a new one, which is absolutely true, but we have had a homegrown record for about 25 years. And what that means is that we can easily track veterans. So it's been an incredibly important tool for reaching out to veterans once vaccines became available. And when the Johnson & Johnson vaccine was paused, we were able to reach 95% of women veterans between 18 and 48 who had received a dose of that vaccine and actually could communicate what symptoms they needed to be on the lookout for and so forth. So all very, very important work where this system was actually acting not only as a care delivery system, but also for our own population, a public health system. So we also went into the pandemic with a pretty strong foundation in telehealth. And as you can see here, over the course of less than a year, we saw almost a 1,700% increase in telehealth visits. But the difference for us is we had been doing telehealth since the early 2000s on a fairly regular basis, a bit of a boutique business line, if you will. But ramping up is very, very different than what many docs I know in practice had to do, which was to learn all about Zoom, this program you never heard of. During the week of just May 9th, we held over 200,000 telehealth visits, and we've expanded virtual telehealth services to include remote monitoring. One example is a company that we have collaborated with called Podometrics. So this is designed to help diabetics avoid the need for amputations. Literally, a veteran stands on a Bluetooth-enabled pad, and when that pad detects a change in temperature, the care team is automatically notified. And in the facilities that are using this device, amputation rates have dropped to 0. That's right, 0, which is really an astonishing achievement. And I think as a result of this pandemic, both the fact that we had to do a lot of care virtually, I mean, not VA, but everyone else as well, remote monitoring has a very, very exciting and bright future. And just in terms of giving you a sense of some of the research, we are collaborating with Defense on a natural history study. And one of our sites actually looked in our own system at the phenomenon of so-called long COVID, and have found that actually for us, the numbers are much likely to be much higher than anyone had guessed. So watch this space, and we are actively monitoring that issue right now. We were also part of NIH-sponsored trials and developed a master protocol for enabling a series of clinical trials across VA. Again, very, very different than each site has to, have their own protocol. We actually transformed to much more of a multi-site baseline from the get-go. And in terms of education and training, one asset we have because of telehealth is that trainees can actually learn a huge amount about telehealth. And the public health emergency guidelines changed supervision so that supervisors could allow trainees to be supervised by someone observing them remotely, which is a very, very big deal, and something that I hope that we will be able to keep post-pandemic. And now I'm going to turn it over to my fabulous colleague, Dr. Taylor.
Thanks so much, Dr. Clancy. I really appreciate your introduction. and wanted to share a couple things about our nursing corps within VHA to start off with, just to give you a sense of who we are and who our nursing corps, who comprises our nursing corps. First, just to reiterate what Dr. Clancy has already shared regarding our 4 statutory missions. Our vision for our organization goes back to the mid-1800s, and President Lincoln, in his second inaugural address, challenged us to care for our veterans who have borne the battle and for the widow and orphan. Obviously, veterans healthcare is our first mission, but as Dr. Clancy mentioned, training and research are also statutory missions, as well as serving to support emergency preparedness for our nation. Our nursing corps currently is over now 112,000 strong. We're about 113,000. And the makeup of our nursing corps is shown here. About 65% of our nursing corps are registered nurses, about 14% licensed practical or licensed vocational nurses, then nursing assistants. Nurse practitioners are 6% of our nursing corps. Certified registered nurse anesthetists are about a percentage. And then we only have a smattering of clinical nurse specialists within our organization. This is a picture of Operation Warp Speed, which was the team that helped with the deployment of vaccine for the nation. And one thing that I share with folks as we talk about our COVID response is that we had a nurse on the upper left in the back that represented VHA, not just VHA nursing, but she was the representative for our entire organization on this team. And I feel that that's so important to underscore, because she had an understanding of how vaccinations were given and within an organization, who gives them, how to deploy vaccines. And she was absolutely pivotal in our successful deployment of vaccine and standing up very readily our nursing corps to be able to administer those vaccines when they were available back in December. Dr. Clancy mentioned deployment of nurses in our 4th mission response. And so I wanted to give you a sense of the number of nurses that we deployed. These are all members of our nursing team, predominantly registered nurses and licensed practical nurses, that we deployed to the different areas that you see here: community nursing homes, Indian Health Service, non-VA or private sector hospitals. We deployed a few staff. Our state veterans homes, which, as Dr. Clancy said, are managed and overseen by the states, but also house our veterans. And then deployment within VA medical centers. So we did send some nurses from VA medical centers that were not hit as hard with COVID and we sent those individuals to other locations. So as of March, from March 2020 to March 2021, we deployed about 4,461 nursing personnel to these locations. It's approximately 4,700 deployments as of today. One of the other things that we did in the Office of Nursing Services was create multiple training modules to help nurses migrate from one area of practice to another and to really mobilize to meet the needs of our COVID patients and the COVID response. So this required primary care nurses or nurses that worked in procedural areas to become either familiarized or refamiliarized with practice in a med-surg area or in an ICU area, an emergency department area, so we could optimize the deployment of our nursing corps within VHA to the needs of our patients and the demands of COVID. We did, as listed here, identify and develop 6 crisis skills acquisition lesson plans and executed these at 20 different locations and reached over 1,600 field-based educators. So we did not only training within our organization, but developed training modules that would be available for external organizations as well. And I just shared this slide to show you our reach of the nurse training that we developed and put on our website. Clearly a lot within the United States and North America, but actually our site was accessed by folks from all around the world. After deploying about 450 of our nursing staff in the spring of 2020, we wanted, as a learning organization, to take a step back and say, what is it that we can learn from these deployments? What can we do better going forward? And so we had listening sessions with about 130 of our staff to ask them structured questions and get some information on what their experience was. And again, in the spirit of a dedicated learning organization, what we needed to learn from their initial deployments so that we could take those lessons and apply them to our deployments going forward. So what you'll see is really 4 different categories of questioning and then 4 different categories of responses. And as was stated actually by one of the previous speakers, a lot of conversation, a lot of feedback that we received was around the limited knowledge of infection prevention and infection control practices in some of the facilities that our nurses were deployed to. So a real opportunity there. Insufficient supplies and staffing shortages. So recognizing that some of the organizations were not staffed with nurses sufficiently to respond to the demands of care that presented during this time. Training was insufficient, particularly in the area of planning and preparing deployed staff, but also planning and preparing infection control and infection prevention practices and basic cleaning, what cleaning supplies, what cleaning solutions should be used in certain areas. So there was an opportunity there. They also told us that in terms of deployment, there was an opportunity to communicate better regarding the different staff roles, and that some facilities who received staff were really unsure how to use them optimally, and wanted to be sure that as we moved forward, that the process to volunteer and to deploy was unclear in some areas. And also they spoke to the importance of providing social support and support for staff resilience for those individuals that deployed, as some of these deployments were really tough assignments and assignments that not all staff were emotionally or intellectually prepared for. And then finally, in the area of culture, the relationships between the receiving and sending facilities was sometimes limited. So an opportunity there, a limited collaboration at the start of deployment to ensure that the mission was clear and was understood by both sending and receiving parties. And then staff and management were somewhat reluctant at the receiving facilities to adopt critical infection control and infection prevention skills and practices. So from our listening sessions with these 130 individuals who did deploy, these were our lessons learned, that the mission and the mission leader need to be clear and clearly identified, that tactical planning and training need to occur prior to deployment and to ensure that resources are readily available for those who deploy, that we need to communicate specifics to the receiving facilities. Resilience training for deployed staff was absolutely essential. Some of them really struggled with their assignments, and they struggled when they came back to their home facilities based on some of the experiences that they had had. The need to standardize policies and processes, and I would also expand this to training and education. And then finally, to engage with community partners earlier to prevent the need for deployment. And really, one of the things that I wanted to share with you today that our staff were very clear about is that, really training, education, and preparation, ensuring that facilities are prepared, that they're staffed, that they have the skill sets to address what they may face is really the most important thing that we as health leaders can do to position ourselves for successful response to a COVID type event. Telehealth and patient transfers in are kind of the next tier of activity. And then finally, staff deployment should be considered only as a last resort. And that really going back to the importance of training and preparation of our staff was principal and foundational for any organization to be successful in the response. So many of our staff that were deployed really talked about the importance of, had we done preparatory work on the front end, even in partnership with some of those organizations that we sent our staff to, they would not have had to have their lives disrupted and be put at some risk as they traveled either across the state or across the country to assist in a dire situation in another healthcare organization. So certainly some key lessons learned there. The other piece of work that we focused on over this last year, and certainly was part of our lessons learned, in the United States, each state licensed their clinicians separate from the others. We do have some compact states, but in essence, you get licensed in the state that you practice in. For the federal government, it is important for us to have the ability and agility to move people around and to practice across state lines and across territories that we have, that we serve our veterans in. And so in November of last year, we published an interim final rule that spoke to our need to assert federal supremacy with regards to the licensure of clinicians for a few different reasons. One, it was a lesson learned in the pandemic that we needed to be able to practice across state lines. Two, as Dr. Clancy mentioned, we really increased the amount of telehealth that we were providing. And so we needed to ensure that clinicians could practice and provide care in virtual space without regard to where they were located and the patients were located. So again, practicing across state lines. And then finally, with the introduction of our electronic health record, wanting to begin to standardize our workflows, standardize our algorithms of care, and therefore we had a need to standardize the roles and the practice of each of the roles without regard to state licensure. So this regulation asserted our authority to our federal supremacy and established or announced our intent to establish standardized practice for about 40 different clinical disciplines throughout our health system. So a really big effort that we began. And this, again, just reiterates what I just explained, that we asserted federal supremacy and also wanted to establish standards of practice for different clinical groups for the reasons that I articulated. We had accomplished this for 3 of the 4 categories of APRNs, for nurse practitioners, clinical nurse specialists, and certified nurse midwives. We did this in 2017, but recognized, again, as the result of the pandemic, how important it was to ensure that we could establish a standard of practice and have portability of licensure across the states and territories in response to the pandemic. So a significant lesson learned for us here. So in terms of the nursing profession and our call to action, and this is really a summary of what we learned, and then as we, as a nursing profession within Veterans Health Administration, as we are looking forward, these are the things that we're really focusing on. Number one, as I mentioned just a little bit earlier, is to prepare our profession specifically and the health system for the next COVID event. Nursing within VHA represents a third of the VHA workforce, so has been the foundation of our COVID response and is absolutely essential to ensure that we as a profession are prepared for the next COVID event, whatever that might be. To ensure that we evaluate the adequacy of nursing workforce, not only in terms of the numbers, but in terms of licensure, in terms of education, agility of practice, and clinical readiness. So going back to the different training modules that we developed and the deployment of those training modules, how do we sustain that preparedness of practice for our nursing corps to ensure that they can migrate very swiftly and very agilely to other areas of practice should they be required to do so, and practice with the skill that's required in those areas. Thirdly, to develop sustainable approaches to supporting resilience. We do have a program office, as we call it, or a department that focuses on whole health. And essentially, this is helping us look at ways for us to maintain our health that may involve meditation, it may involve exercise or other practices that help support our resilience. But as we discuss resilience for our patients, we think it's absolutely important that we have sustainable approaches for our clinical staff, nurses and physicians at the top of that list. Next, for us anyway, is to optimize the compensation models to ensure that all four of our statutory missions are met. We have some real challenges because our compensation models for nursing are established by law, by Congress. And so the ability to increase the cap, for example, in our nursing pay is something that we need legislative relief to accomplish. So there's a lot of work for us to do to ensure that we have agile models of compensation that support our staff nurses as well as our nurse providers. Next is developing a strong pipeline for the next generation of nursing workforce. And this is leveraging our relationships with our academic affiliates across the country and strengthening those programs that allow us to bring in student nurses, graduate nurses, doctorally prepared nurses into our programs and help us with addressing our practice needs, but also help preparing that next generation of workforce for the type of nursing practice that we believe we're going to need going forward, particularly important in the areas of infection prevention, in the areas of primary care, and the areas of long-term care. Next is to enhance the support for nursing research. There's so much we believe that we can learn regarding nursing practice and the nursing experience in the COVID response, and think that, at least for our organization, we really would like to capture that and learn more from this past year and a half, and believe it is important for us to do so via nursing research. So I want to put some more energy and effort into this area. Ensuring that our health policy articulates the nurse's role, responsibility, and authorities as we provide health care. And this has been a focus of the Office of Nursing Services within VHA to really ensure that as we review national health policy for our organization, that it's clear, again, given the profession represents of the third of the workforce, let's be specific about what nursing's role is here, what the responsibilities are, and what authorities and what decision-making rights they have as we make decisions around healthcare. That we link governance structures for nursing and governance structures for the entire health system and ensure that we're making decisions, that VHA is making decisions around its nursing corps and its nursing workforce that's in sync with the direction of the profession within our industry and within this country. So it's something that we have made some strides on this last year in setting up, establishing a national board for making nursing recommendations to VHA and our VHA governance, which I think is going to be very helpful and exciting for the workforce and essential for the workforce of the future. Preparing the workforce for different delivery models. One of the things that the Office of Nursing did, another piece of the response, was develop surge and crisis level staffing models and approaches to ensuring that we can provide services and care as the demands increased in certain geographies. And I think there's a lot of work that we can do in this area yet in terms of exploring what worked and what didn't work in the delivery models, how we might tweak that, and again, how do we position ourselves to be successful for the next potential COVID event. Addressing the standardization and portability of practice to support these care models, that speaks to the work that we're doing with federal supremacy and the standardized scopes of practice or the standards of practice that we're in the process of developing. Also developing models for using technology to support non-institutional care. And this is particularly important as we think of our elder care strategies and those patients who are older. What our experience has been is it really drives us to test technologies and to test approaches that support veterans receiving the care that they need to receive in the location that's most supportive to them. And hopefully that's in a non-institutional location. And then finally, strengthen the public health approach to health promotion and disease prevention within our organization. And certainly we see this as something that the profession of nursing has a leadership role in, and a significant role in developing health policy around health promotion and disease prevention. So with that, I will stop. It's been a delight to be part of this conversation today. I really have appreciated some of the previous presenters, and we'll stop and see if there are any comments or questions. Thank you.